Well, kidney stones are very common. They occur in approximately 12% of people. So it's very common and it's extremely painful. Patients usually present with pain in the loin, which radiates down to the groin area, and they have nausea and vomiting. It's important to check that they don't have a fever, because if patients have a fever, that's a medical emergency and we have to drain that kidney straight away. Our management generally depends on initially diagnosing the problem. So the way we diagnose the problem is that we do a urine test. We check if there's blood in the urine. That gives us an indication that there might be a kidney stone. That also allows us to check that there's no infection. The imaging test that we do these days is a CT scan, a non-contrast spiral CT scan. And this is very, very accurate, and it usually tells us where the stone is, the size of the stone, and the degree of blockage or obstruction to the system. And the management then usually depends on the patient's symptoms. Do they have ongoing pain? Do they have a fever? And on the size and location of the stone. So if patients have a small stone, say less than 4 millimeters, we will monitor them conservatively. If the pain settles, we will monitor them, give them analgesia. They're usually discharged. We'll do regular scans and wait a certain time period and let them see if they pass a stone. If they haven't passed the stone in a reasonable time period, we will then intervene and remove that stone. If they have a larger stone, greater than 6 millimeters, the chance of that stone passing is very low. So we would generally treat that stone. And that stone may be located in the ureter, the tube that comes from the kidney to the bladder, and we generally treat that with ureteroscopy, which I'll explain shortly. Sometimes we also find very large stones, staghorn stones, which occupy a lot of the kidney and the drainage system. And they're quite complex and they require different forms of treatment. There are essentially 3 or 4 types of stones. The commonest stones are made of calcium oxalate or calcium phosphate, and hence you can see them on plain x-rays. They occupy about 90% of all the stones. Sometimes you get infective stones or struvite stones, which usually occur in young females who have recurrent infections. The other type of stone are uric acid stones, which are related to patients with gout. They have increased uric acid metabolism. Very rarely patients will have cystine stones, a congenital abnormality where they have abnormal absorption of cystine from the urine. They form these stones. In terms of the treatments that patients have, a ureteroscopy is generally used when the stone is in the ureter, that is the tube from the kidney to the bladder. We pass a thin telescope either through the eye of the penis in males or in the urethra in females. We go up the ureter, which is the tube that joins the kidney to the bladder, and we get to the stone. Usually the stone's too big to come out by itself, and we have to fragment the stone. So we usually break the stone with either a lithoclast, which is an instrument that's like a mini jackhammer, or a holmium laser, which is very precise. It's like a surgical knife. It breaks the stone in very precisely, and then we take out all the little pieces with a basket, a Dormier basket, and remove the stone. I usually plan to remove all the stones. Some people break the stone and allow patients to flush the stones out, but my aim is usually for complete clearance. Now, I also do ureteroscopy for complex stones in the kidney, where we go up with a flexible ureteroscope that bends all the way up to the kidney, and we can go round the corner of the kidney and treat the stones and treat it with a laser. So in patients that have had stones that are not suitable, or it's a lithotripsy, or lithotripsy doesn't work, then we would use flexible ureteroscopy and laser treatment. I was one of the first in Australia to do that, and we've been very, very happy with those clinical outcomes. Usually after ureteroscopy, we'll put a stent in, a plastic tube that curls between the kidney and the bladder, which ensures that the urine flows out, and then we remove that either with local anaesthetic gel or a light anaesthetic in usually 1 to 2 weeks. Now, stones that are present in the kidney are usually treated with lithotripsy. This is shockwave treatment that's given externally. A patient lies down, usually under an anaesthetic, for about 40 minutes or so and has external energy given to the stone, and remarkably this stone can fragment and break into little pieces, and then we wait for the patient to pass these little pieces. The success rate for lithotripsy is about 80 to 85%. Some stones you don't have success straight up and you have to have multiple treatments, and some stones unfortunately are refractory to lithotripsy. And if they are, then we do the flexible pyloscopy and laser treatment. Sometimes if we have a very large stone in the kidney, so-called staghorn stone, we will do a percutaneous nephrolithotomy. It's keyhole surgery where we puncture the side of the kidney, we go into the kidney, we find the stone, we break the stone either with a lithoclast, which is a mini jackhammer, or with an ultrasound, which sucks up some of the fragments, or with a laser. And then we remove the fragments that way. Patients are usually in hospital for 2 days, There is some concern because we do have to go through the kidney for that procedure, but certainly it's preferable to a big open operation. Now occasionally I've also removed stones laparoscopically with keyhole surgery. So if we have a very large stone in the kidney, renal pelvis or the ureter, we can go in with keyhole surgery and remove it, and patients are just in hospital overnight. Now the important thing with kidney stones is to get the stones analysed, get blood tests done to see if patients have abnormal uric acid or calcium level, and check that there's no abnormality. Sometimes we do a parathyroid level because the parathyroid gland here produces hormones that can lead to increased calcium levels. If patients have recurrent stones, I usually refer them to one of my colleagues, one of the renal physicians, for a full metabolic evaluation so that we can try to minimise the chance of stone recurrence. So the important thing with kidney stones is to ensure that you do whatever you can to prevent them recurring. The most important thing is to increase fluid intake. It's very simple. There's little molecules in the urine. When they're close together, they join, they form a stone. When they're far apart, they don't. So you have to drink 2 to 3 litres a day. There's evidence that homemade lemonade is better than water itself. I tell patients that they should ensure that their urine's clear and they're passing urine every 2 to 3 hours. So that's really what we do with kidney stones. It's a common condition, but there's lots of treatments, a lot of good treatments available. And if you have recurrent stones, you should have a full metabolic evaluation to minimise the chance of them recurring.